Okay, thanks, Scott. And would like to thank also the organizers for inviting me to speak. And most also I'd like to thank our guest speakers who are here as well. For traveling the distance. For me, I live here just across the road in South Street, so it took me only five minutes to walk. So I'll be speaking about treatment options, although at first I'll touch a little bit on the diagnosis briefly and symptoms, as they were very well covered by Dr. Desal, but I'll go quickly over these things. These are my disclosures. So this is a slide that I like to present when I talk about patients who have monoclonal disease. So basically, this comes from lymphocytes, B lymphocytes, or type of white blood cells. Okay, they're polyclonal. They are multiple colors that you see at first, and then they develop mutation, then become a monoclonal. One of them becomes abnormal and start populating. As you see, the red cells that are growing there. So it's all polyclonal at first, multiple colors, and then one cell comes, it's a bad cell, then start growing, producing the M protein. This is the bad protein that manifests the disease later on. So, and the way of diagnosis this is what we call serum protein electrophoresis. The picture far in there, it shows the graph there, it shows the normal serum protein electrophoresis. So if you see that there is no spikes there, okay, it's all within the normal, okay, polyclonal. And then when patients, they develop those monoclonal cells, the red blood cells, these red monoclonal cells, they are the ones that produce the monoclonal protein, which when we do the serum protein electrophoresis, it shows me the monoclonal protein going up. So that's how it all starts. As mentioned, this is a type of non-Hodgkin lymphoma and mingles also with plasma cell dyscrasia or multiple myeloma. So, but as lymphoblastic lymphoma in the marrow manifestation, this is considered an indolent lymphoma, a slow-growing process, slow-growing disease. Patients, they can have many years and disease progress before they have symptoms or needing treatment. These diseases falling on the category of indolent are slow and also, unfortunately, we call patients is not curable. It's treatable but not curable. And patients have no symptoms, they don't need treatment. We'll just sit tight and watch those patients. So the Waldenstrom has basically, if I want to split it, we can maybe say two components. The bone marrow, lymphoplasmacytic lymphoma, and outside the marrow is the M protein. And the symptoms of the disease can be based on these two components. Now, to mention a little bit of epidemiology here in Nova Scotia, as Dr. Desal mentioned earlier, that it's a rare disease. It's about 1% patients. We looked at our patients in Nova Scotia between 2002 to 2007 and tried to see the incidence of all lymphomas, including lymphoblastic lymphoma, okay? And we know that's about 5% of non-Hodgkin lymphoma to be a lymphoblastic lymphoma. And when we compare this to the WHO book, which is the international incidence, okay, showing the lymphoblastic lymphoma in the WHO book is about 1.4%, as compared to Nova Scotia between 2002 to 2007 is about 5%, a little bit higher. When I was a resident here about 8 years ago, I was talking to Dr. McDonald always to say, I feel those patients are actually far more here based on what we see. I feel it's more than 1%. So this study showed me this is actually, we reviewed this and we looked and actually it shows about 5% of our patients. So again, it's a rare disease, a little bit more male predominance, okay? And familial prepositioning has been described in about 20%. Etiology, we look at a few things, but most of the time we don't have a good explanation as why this disease has developed, okay? Sometimes just say it's bad luck, okay? So infections as hepatitis C virus have shown that it can increase the risk of Waldenström. And we always test our patients in that time diagnosis for viral infections. So, clinical presentations for those patients, okay? As I said, majority of patients, they can be asymptomatic as a start, okay? And then the presentation will be based on either the bone marrow infiltration or the M protein. And the bone marrow infiltration, this patient can have fatigue, having fever, sweats, or chills. These are what we call the B symptoms, okay? It's possible patients who we're watch and waiting them, they might have these symptoms once a month or once every few weeks, okay, for a couple of days, then goes away. This is not an indication for us to start treatment, say just best sit and watch. I have Dr. Orm Hainsey, or one of our senior hematologists, he always tells me, these diseases, they wax and wane. Just sit tight and watch and see them, okay? So it's always good to sit down and watch. The fever, sweats for a couple of days, usually settles and see how patients go. The bone marrow infiltration, okay, as these lymphoma cells increase, okay, the other cells go down, meaning the healthy cells, okay? So if the lymphoma cells increase, you might have your red blood cells production goes down, so the hemoglobin goes down, so your energy goes down. And our guidelines say if patients have hemoglobin less than 100, those ones we would treat them. The hemoglobin range, we use a normal range between 120 to 160. However, we say if patients for this disease, if they are symptomatic, having fatigue, hemoglobin less than 100, we treat them. I have a patient, I remember a couple of years, he was referred to me by his family physician for a hemoglobin of 90. Okay, did a blood work and did the workup, bone marrow biopsy, and then confirmed lymphoblastic lymphoma. He tells me, I don't know why my family doctor sent me. I was going to do a routine blood work, and he told me, no, you have to go and see a hematologist. And he says, I am active, I have no fatigue, and actually I'm cycling quite close to 50 kilometers a week. So, okay, I don't do that. So his hemoglobin was around 90. So, okay, our guidelines tells you to treat those patients. I think it's best just to watch and see. So again, to emphasize, looking at numbers, it was not the most important thing, is the patient, how they're doing is what we do. Okay. And then large lymph nodes and also large liver and spleen, those can cause also symptoms. The lymph nodes, is there a need to follow up routinely those patients and watch them and see how big by imaging? No, it's best just to monitor, because ideally an indication for treating based on the lymph nodes, if the lymph node is like 10 centimeter, a bulky lymph node have no symptoms, those guys will treat. And very unlikely to have a patient have a lymph node at 10 centimeter and have no symptoms. The manifestation or presentation due to the monoclonal protein, it can be in hyperviscosity. Basically, you see in the picture on the side, this agglutination of the cells, okay, well, plus IgM there. This would lead to sluggish flow of blood, okay? If it's in the head, sluggish flow, then you'll have headaches, okay? If it is a sluggish flow around the eyes, then you have blurry vision. You can't see, you can't double visions, okay? So this is what we call hyperviscosity. The blood flow is kind of difficult to go through the vessels, okay? Cold agglutinin, basically hemolyzing and leading the hemoglobin to go down. This basically is not like the hemoglobin going down because blood cells in the marrow are not produced enough. Sometimes those patients, you might do a bone marrow, you find, yes, they have disease, but not significant, but you look on their smear, actually it's very hemolyzed. They're destroyed, those blood cells, leads to anemia, so they get tired and fatigued. Then those patients, they would need treatment. Manifest neuropathy also as a part of it, and cryoglobulinemia, and the last is amyloidosis, which is a different disease entity, but can be associated with lymphoblastic lymphoma. So these are percentages for the symptoms, basically ranging all between 20 to 30% in those patients when they present either one of these manifestations I mentioned. Findings can be seen as mentioned, the hyperviscosity, having Raynaud's changes, having the hyperviscosity, either central nervous system or on the eye changes. So we have the investigation and workup varies. We start basically after we see the patients, assess them, take a history from them, and to do a physical exam. Then this would directly me further to do the investigation and what to investigate. Okay, simply we start with a CBC and look for the blood counts. Okay, and then this would directly more if I need to do, like if the complete blood work count is normal, but patient has an IgM. Okay, and they're doing fine. I don't need to go all the way to do a bone marrow biopsy at that visit. I'll sit tight and say, yes, you do have monoclonal protein, and this would be a diagnosis of Waldenstrom, and now asymptomatic, or it could be MGUS even, and now we sit down and watch. We don't have to go all the way to do a bone marrow from the first visit. Because sometimes what happens here, there are patients who are going to get a CT scan for any other reason, okay? And then they find a lymph node in those patients. They get a lymph node biopsy that turned out to be a Waldenstrom or lymphoblastic lymphoma. Do we need to go and do further investigation, do the bone marrow to confirm if the CBC is normal, and the patient has no symptoms and don't need to treat? Might hold off and tight and watch this patient. So the testing has CBC, kidney function, liver function, always good to have as a baseline, and basically serum protein electrophoresis, and then the bone marrow biopsy, and afterward it depends if there's evidence of, as I said, hemolysis of blood destruction, then we do the hemolysis workup, also a CT scan if needed in the bone marrow. And the last thing, if there's evidence or concern this patient might have amyloidosis, then we do a fat pad biopsy. Not routinely, we do fat pad for old patients. And ophthalmic evaluations or vision, we send our patients here to ophthalmologists if they come concerned with some blurry vision or have concerns that there could be a hyperviscosity. As a part of the workup, if we have a definite at the time presentation, this patient have hyperviscosity and have high IgM, we know this Waldenstrom and this hyperviscosity, we start treating as, and then ask the ophthalmologist to see the patient to assess further. So autoimmune hemolysis is basically secondary to this IgM. Those patients, we might have patients who are presenting, the only main issue is hemolysis. They're hemolyzing, they're destroying red blood cells, so we need to address that. I wouldn't go in details here, molecular biology, but they're, as treatment advancing, also luckily the investigations and confirmatory testing we have are advancing as well and improving. And MYD88 as a molecular testing, it's associated with a higher percentage, more than 90% of patients of Waldenstrom, lymphoblastic lymphoma. And luckily here we have access to do this testing. Sometimes, because when we do a lymph node biopsy, sometimes it's hard to confirm what type of lymphoma it is. So luckily now we have access to do MYD88 testing to confirm. Also the CXCR4 as well mutation. So these are associated with Waldenstrom, and we do sometimes need these testing to confirm our diagnosis. So, treatment. Does everyone need treatment at diagnosis? It's always hard when a patient comes to me first visit. We sit down and chat and give them the information. And okay, so what is this disease you're talking about? When I say cancer, basically, if you want to go to molecular level, this is actually truly cancer, because cancer is there is a cell that's changed, produced abnormal shape, and is not doing its function right. That's cancer. So if you ask me what it is, I tell it cancer, then, okay, doctor, you tell me it's cancer and you want me to go home and forget about it. It's hard, right? So I tried first to see those patients the first. I know it's hard to gather all the information, so I see them again the following few weeks, then again in a few months. Then as patients learning more and grasping more information and they know, they understand that they're not symptomatic and we know what we're watching, then we slow down on the follow-ups depending on how their blood work and how is everything going. Okay, so there are evidence. So the other question, okay, this, you tell me I have cancer, it's a small amount, why don't you blast it and get rid of it? So then that's it, we're happy and living fine. There are many studies that shows that no, there's no need to advance and start. And actually, sometimes the treatment can be harmful more in side effects as compared to not treat. So the study basically shows here patients followed over 10 years, okay? And if you see, I just show it clearly, if you see the around between the 40 and 60% and 50%, those patients, they took almost 3 years or more to decrease from there, from the start, from 0 time all the way to 3 years, 50%. So you have in 3 years, almost 50% of your patients needed treatment, okay? And then if you go to 10 years, okay, you have almost 10% of the patients had not been treated yet. So almost 10 years. So, yeah, asking the patient, like, in 10 years now, would you want to take treatment now, side effects, or maybe in 10 years you would be still living fine and never need treatment? So there's evidence to show us that those patients can do well. So it's best always watching and waiting. So we talked briefly about the indication of treatment, let's say B symptoms and lymphadenopathy, splenomegaly. The cell counts, as I said earlier, but still, these are as an indication for us as doctor, but sometimes, as I said, I have been bad in saying, patient looks fine, so I just want to sit tight and watch and see also if it's truly declining more or not. The hemoglobin less than 100, we use platelets less than 100 due to the infiltration, or patients who have hyperviscosity, those guys will treat them, okay? Neuropathy or also renal impairments as well. Amyloidosis, if they are developing amyloidosis, then those patients also need treatment. So we need to look at treatment strategy for those patients depending what kind of symptoms that brought them in and what to address first is in treatment, okay? If a patient at first will watch and wait, but now they're progressing, starting having symptoms. They're having symptoms due to the IgM, the monoclonal protein, as in having hyperviscosity, okay? Then those patients will need plasmapheresis first. However, this plasmapheresis is just like a dialysis machine. They're hooked to a machine, blood goes in and goes out, and you filter this IgM. So when you filter this IgM, you don't filter the cells that are making the IgM, okay? So I clean, this is basically almost like a Band-Aid. I'll fix it this way, but the problem in a few weeks is gonna start rising again. So this is, but it is as a start treatment to avoid this emergency. Now, the hyperviscosity situation, we look at it as an emergency situation. We need to plasmapherese those patients. So this is the one strategy, is plasmapheresis. And then the other strategy is that the cytoreductive, we call it, or cytoreduction, basically cyto as cells, we need to reduce these cells, okay? Give treatment to reduce their cells down, okay? These monoclonal plasma cells, we need to calm down, and unfortunately, we don't have yet treatment to knock them all out. We need to reduce them as much as we can. And then the last, after you reduce them, you need to maintain those patients then. So we have maintenance therapy as well. So before starting the therapy, there's always a question to ask if patients, this is the first day we meet, or this patients came to the emergency and this is the first day we meet, okay? As patients come in with hyperviscosity symptoms or not, and how high the IgM. It's true with 100%, there's no correlation 100% with the level, though the hyperviscosity is the most important. If patients have hyperviscosity symptoms, we would treat with plasmapheresis before the treatment with other drugs. Now, how about if the patient has a high IgM already, but they don't have a hyperviscosity symptoms? What we do, and our practice here in our center especially, is that we try to do plasmapheresis to decrease their IgM, okay, before we start cytoreductive. Because we have some concerns, especially now we use rituximab, we'll go after later on, it can flare up this IgM a little bit higher at the start, then goes down. So we try for those patients to take a little bit off plasmapheresis first. So we talked about the hyperviscosity symptoms. So just I find this picture is a bit quite interesting online. Just to see the changes for those patients who have hyperviscosity, engorged vessels on the far end there, before plasmapheresis, how it is, and then after plasmapheresis, the blood flow becomes better, the visual acuity becomes better for those patients. Okay, so here's the thing. When we talk the first time, we say there's treatment. Some patient might go online, have a look. There is a long list of medications, can say this, we can use for treatment of patients who have Waldenström. Okay, so to divide them in categories, alkylating agents, I'll say the bendamustine is alkylating Purine analog as well. So bendamustine is one of the drugs, cyclophosphamide, chlorambucil, melphalan. And then Purine analogues, we have the fludarabine, pentostatin, clodarabine. And then there's the new drugs, the monoclonal antibodies. We have rituximab, ofatumumab, and there are more new drugs as well coming. Proteasome inhibitors, this is like bortezomib or Velcade, and also the new drug also we use mainly for treatment of myeloma is carfilzomib. And then the ibrutinib, bruton kinase inhibitor, and then IMiD as well, lenalidomide and thalidomide. This is what we call them immunomodulators. So it's a very long list of medications here to see. And just before we talk about each treatment, and then I say what our guidelines here and how we built our guidelines, just to mention what are our goals from the treatment, okay? Or what is the monitoring response for those patients. So our goal for patients who need treatment is what we call remission. And remission, as we say, is not cures. Remission is the disease the lowest possible can be with treatment. So it can be a complete remission, what we'd like to get for those, is basically disappearance of the monoclonal protein on testing, serum protein increase and immunofixation. So when we do this protein level, we look for it, we don't find it at all. So this is complete remission. And very good partial remission, okay, those patients, they have at least 90% of the level, okay? Then partial remission of those patients having 50% reduction of the level. And then some patients, they might have a minor response, 25%. And stable disease, yes, unfortunately, there are some drugs we try. Patients' disease or IgM level and lymph nodes, they stay the same. They do not improve. Progressed disease, basically further increase of the disease by 25%. And this is, we look at it either if they are relapsed, like if they were in remission, then they got treatment, they are in remission, then now relapsing, so we look at 25% increase, okay? Or if they are in treatment already, but they are unfortunately still progressing despite therapy. So 25% is the number we look at. So treatment has been evolving over many years, okay? Start was the alkylating agents and Purine analogues from 1980s. Chlorambucil, it was the oldest to start with, and also cyclophosphamide, either in a single agent or then becoming as a combination therapies as well. We still tend to use sometimes the chlorambucil here, patients who are not able to tolerate other drugs who might go to as a last resort or try it as well. The Purine analogues, fludarabine, this showed a very good response in treating Waldenström, although it has a toxicity very high side effects. The response in treatment can be up to 90% of those patients. So has been looked at between the chlorambucil and fludarabine, and the chlorambucil response rate was about 36%, and basically for fludarabine was higher at 48%, progression-free survival of 36% for those patients. And that study showed the fludarabine that was higher than chlorambucil response. Toxicity, basically it can be from secondary cancers. Those patients also in treatment, they can transform as well. And as I mentioned earlier, we reserve this option as a last option and as we don't have any alternative, and for patients who are unfit and elderly. So the fludarabine, as I mentioned, is a toxic drug. We are less and less using it now for patients who have relapsed Waldenström with the newer agents coming in. The short-term effect or issues with it is that it can cause white blood cells and neutrophils can go very low, and these are the cells that help fighting infections. And the problem with that, all our therapies, they may decrease and go back up, but fludarabine can cause a slightly prolonged, what we call neutropenia, so patients can be at a higher risk of infections. And those patients, usually we give them fludarabine, we always give them a prophylactic antibiotics to go on while they're on treatment and afterward for a year at least. The long-term effect from fludarabine, also secondary malignancies is possible. In 6 years, it's made to be 3.7, and also transformations. Then in the 2000s, that's when the treatment has changed dramatically with the arrival of the monoclonal antibodies. And mainly speaking about the rituximab, which is anti-CD20 antibody. So this start first in 1997, clinical trials, then start fast moving forward until becoming the first line of treatment. And one of the studies in rituximab clearly improves outcome in patients with indolent lymphomas, basically when it's combined with other modalities, R-CHOP, and shows that patients who had rituximab, you see the line higher up, that's rituximab plus CHOP, okay, therapy, and shows patients did much better than patients who had CHOP alone down below on the orange line. So this has been our first line therapy here for a while. Is you give to R-CHOP or RCVB, two similar regimens. We use them for those patients who have Waldenström. There has been evidence to showing also a single agent rituximab, okay? I showed now this is combined, either R-CHOP or CHOP alone, but then also there are multiple trials or studies showing that rituximab alone as a monoclonal antibody can give an effect on treating patients with Waldenström. So unfortunately here, access to as a single agent, which is interesting sometimes to look at, cannot get rituximab alone, okay? We need a combination therapy. We have it approved for us as a combination therapy. We look sometimes, we have patients that are in 85 years of age and feel, okay, combination chemotherapy can be a little bit hard on those patients, okay? So what we try, the other regimens that we haven't listed in our guidelines here is to use lower of these, and basically this is RCD, which is rituximab, cyclophosphamide, and dexamethasone. So this is still tolerated, and we have access, can get this way and do it for our patients. So I mentioned a little bit earlier that patients who have high IgM, and we are going to give them treatment with monoclonal antibody, the rituximab, we watch and worry about the flare-up of their IgM. And this is actually all proven in studies. And we do plasmapheresis for them. Sometimes when the immunoglobulin is not, like it's a borderline high, what we do is just give a first cycle, especially sometimes it's hard to arrange the plasmapheresis within like a couple of weeks or a time manner for this patient to start chemo. We might give the first cycle without the rituximab. We hold rituximab back. We give our standard other rest of the regimen in order to lower a little bit the tumor burden. Then we go and add the rituximab to the following cycles. So these are other regimens, as I mentioned, our CVP and RCD or DRC. And just briefly to mention here, the studies showing the response rate for the Purine analog, so as in combination between rituximab and fludarabine. We used it mainly in relapsed refractory patients as well, so it does show there's response, okay? But the biggest concern also for this regimen, either FCR or FR alone, is the risk effects. Now, then a new drug came in, okay, which is the bendamustine, okay. It has similar choosing structure between alkylator and Purine analog, okay, and meaning like the cyclophosphamide and fludarabine. So bendamustine is a very good drug, okay, and has been studied and looked at patients who are getting, as I mentioned, that we were giving R-CHOP or RCVB as our first line, and then their trial came and showing between patients who get bendamustine rituximab compared to the R-CHOP. As you see, the blue line is the R-CHOP, our previous therapy, and the red line is the bendamustine rituximab, which is now becoming our standard of care here. And you say time in months, so the BR given longer time in months compared to the R-CHOP, okay? And then it's basically 69 months compared to 28. So since then, since the study here in Canada, and talking specifically our center, is that it's as a first-line therapy for patients who are fit to get treatment. As what we give them is bendamustine and rituximab. We give it 6 cycles. Okay, first cycle, usually the cycles start day 1. We give rituximab plus the bendamustine, and day 2 we get bendamustine. And every every 28 days, we repeat the cycles for a total of 6 cycles. The good thing about this regimen is compared to the R-CHOP, toxicity is less, and basically there is no hair loss with it. Nausea can be a little bit more, but we have good supportive therapy that helps with it. Now, after we finish the 6 cycles of treatment and evaluate those patients, okay, as I mentioned, responses, we're looking at best to be a CR. Most important is that patients can be a very good response or partial response. What I look mostly is that did the symptom that the patient had before starting go or not, okay? That's the most important success here. If it is gone, then yes, we are on to step 2, and patients is in at least in the partial remission. Then would go afterward on the maintenance rituximab. So, okay, there are studies. Waldenstrom is not a very common disease, so to have a big study to show the efficacy and evidence of the maintenance or any other studies is hard. So most of the studies we find they are actually included with patients who have other types of lymphoma as well. But overall, maintenance rituximab, it shows for indolent lymphoma, those patients, they do well and they have a longer progression-free survival as compared to patients who do not get the maintenance. So, and from that and treatment approach for patients who have Waldenstrom lymphoblastic lymphoma here across Canada, as a first line, is looking for patients who are younger and fit, is bendamustine and rituximab as a first-line therapy. That's what we use here in our center, okay? And then following that, we have also access to give rituximab for maintenance for 2 years. And the last changes we have here in our center is that now rituximab is we give it as sub-Q, subcutaneous injections. So those long hours of coming to the medical day is less now. So patients come, get a sub-Q, 15 minutes, and they go home. So we have applied this change to patients with indolent lymphomas, basically. Patients who are elderly, unfit, basically, then we see chlorambucil as an option, okay? Depending how we see the patients is, sometimes RCD is considered cyclophosphamide, dexamethasone, and rituximab. There are other new drugs coming. We still don't have access for all of them, but we look sometimes always for our centers that if we have a clinical trial for those patients as well for drugs they will tolerate, then we'll try to enroll. Now, what if the patient relapses after this treatment? Duration of remission is always a factor, okay? If patient had a treatment and then now has many years as compared to a patient who's just in a few months, relapses or they relapse during the maintenance. Luckily, in lymphoblastic lymphoma is usually very easy to treat. Most patients respond very well to treatment. But if patients has had a long period of remission, then I can consider repeat BR, and also can consider the older therapies we had, like the R-CHOP, RCVB. Always in our center, we had tried to advocate patients go into clinical trials on relapses. Now, also, how aggressive is the disease and how fast this patient relapsed and how fit the patient is, we can consider other line of modalities of therapy is after getting those patients in remission again to talk about stem cell transplants. So we do auto transplant sometimes patients who have a very aggressive disease or behave aggressively their disease. So other drugs, proteasome inhibitors, okay, they Proteasome or Velcade, okay. So it's basically this drug, and we use it commonly and as a first line for multiple myeloma. As I mentioned here, those diseases have lots of similarities. It did prove efficacy, and the regimen of Bendamustine Rituximab and dexamethasone had lots of evidence on it, and it's used as well. We don't have access to it. However, if we have patients who are relapsed refractory patients and we don't have an alternative, we don't have a clinical trial, we still as a group here go and try to get funding for this patient to go and proceed with this treatment. Now, we can also tailor patients based on if there is any other disease that, or if there's evidence of amyloidosis for those patients, so we can tailor management. Amyloidosis, we know it's part of treatment is Proteasome, so for those patients who have amyloidosis, then we can tailor, we can get access to this drug and give it to those patients. So basically is that, yes, we have guidelines, yes, we have indications what to start first, what to start second, but always we have to look at the patient, okay? And these patients look at their age, and if there are either health problems, their fitness, performance status, okay? And also the disease itself, how rapidly it is progressing, okay? How aggressively. As I mentioned, this disease is, most of patients are easy to treat, but we encounter sometimes patients are very difficult, they're not responding easy. So do we shift from what we use and we get something, other things that's compassionate release? Yes, we do, okay? So here comes then ibrutinib, okay? So ibrutinib has been approved in Canada since April of 2016, and funding here in Nova Scotia is still pending, and we get access to it via compassionate release, okay, and also via clinical trials. So who should use ibrutinib? Okay, patients who have had or failed previous therapies, okay, patients basically who are relapsing, patients have a rapidly flaring, progressing disease as well. So I mentioned a long list of medications, okay, and mentioned what we're using here as a standard of care. Just a quick snap at the coverage here in Nova Scotia. We know that Pharmacare is the drug plan we have for patients, and other group patients, they have their private insurance plans. But I'll mention what Pharmacare gives us access to. So Bendamustine, we do have access to it as a first line for patients who have Waldenström. Along with that, Rituximab as well for during the induction of 6 months, and then following that, the maintenance. Then other drugs, ofatumumab is not covered. And we had a study here, ofatumumab plus Bendamustine, which had for patients who were not responding well to the rituximab prior, because ofatumumab is just a newer anti-CD20 antibody. So those patients, we had a study for them here, and did have a negative results. Now, afterward is the Proteasome, as I mentioned, and here we don't have access to it. Carfilzomib also showed some evidence, but we don't have access either to it. Now the ibrutinib, it's approved in Canada here. However, we still do not have access to it. We get it very easily, I would say, nowadays as compassionate. And also we had a clinical trial. We had some patients on it, and we're looking to finding other clinical trials to open here in our center. And I think soon will be coming, basically, for patients who's relapsed refractory. But as I highlighted this, it's still easy for patients who need it. We can get it for those patients. Now, how this coverage comes in play. We do have our tumor site group here and the hematology division here in Halifax. We do grand rounds on a weekly basis, but we do tumor site grand round, which is if there's any hematological malignancy, we take this disease and we look at what are the updates, what are the treatments, what are the investigations that are new as well for this disease, review it all together as a group with the pathologists, and basically afterward we proceed and submit if we see there's guidelines, and actually this drug now proves to be very beneficial for our patients and we need to proceed ahead. So then we submit our request to the, we call them people in downtown, but the Department of Health, and we supply this to them and see, and negotiation there and goes on. So part of our division here, we do a lot of clinical trials. We participate in a lot of clinical trials, and wanted to pick one of the most recent trials we have participated on for patients who have Waldenström, and this trial basically looked at patients who have Waldenström and treating them with rituximab and ibrutinib compared to rituximab alone. So this trial was recruiting from 2014 and has closed recruitment now. We have some patients on it, and the final results will be should be in January 2019. So this trial, looking at those patients, starting rituximab plus ibrutinib, which is a pill, daily you take it, and compared to other arm, which is our patients taking rituximab plus a placebo, which is just a tablet to take, sugar pill, and see then afterwards see the results of these patients. I think it will be very promising, and this is something that we will look at and help into negotiating further and the enrolling and covering ibrutinib for our patients here. So in conclusion, the Waldenström treatment has changed significantly over the past decade even. I remember when I was a first-year fellow back 2010, I did my tumor site group grand round and was for Waldenström disease then, and I didn't have much to say. We're talking RCD, Clarence-Bissell, our job. We're saying Bendamustine is almost looming there. So things since then has changed dramatically, and I think they will keep evolving with the newer drugs also coming.